Dyslipidemia has been one of the major risk factors for development of coronary artery disease, along with high blood pressure or hypertension, diabetes and smoking, etc. There are minor risk factors also, and the coronary artery disease is progressing so rapidly in our country, especially with the younger generation. So we have to target dyslipidemia very aggressively. When I was a student, we were all the time talking about cholesterol, and only drug available that time was cholestyramine to reduce the cholesterol. But we found other way around. Instead of reducing the cardiac deaths, there are other complications because of this molecule like cancer, etc., etc. So that drug was ultimately was not no more used. Then we got gemfibrocil. That also was there available for some time, but subsequently we had to again stop using the molecules. Statins were the revolutionary molecules which were available for the treatment of our patients, and they are still stood the test of the time. We had a lot of statins, but ultimately now we have rosuvastatin and atorvastatin available, and these are very effective molecules. Both are equally potent. Maybe rosuvastatin is slightly potent than atorvastatin. Atorvastatin is safe in kidney. Atorvastatin has no side effect on the brain. So these are minor differences are there. There are some papers which said rosuvastatin raises the new onset diabetes marginally, but when we are using rosuvastatin for diabetic patients, what is the fear of raising the new onset diabetes? Now, apart from reducing LDL cholesterol, LPL, small a, apolipoprotein B, these statins also have what is called the pleiotropic effects. They stabilize the plaque, they increase the fibrous core of the plaque, and therefore the vulnerable plaques become more stabilized, and therefore they don't rupture, leading to an ACS or an acute ST elevation or MI. But side by side, it is necessary that statins should be used in high intensity to protect them from progression of coronary artery disease. At the same time, you have to target the LDL goal. There was a time when we were targeting 100 mg/cent, then newer studies came and said lower the better. So we started targeting 70. We started targeting now 50 mg/cent. Even the Lipid Association of India has recommended less than 50 LDL cholesterol should be the target. Now in the bargain, you go on increasing the dose of statin, and what happens that patient may develop side effects to statins like muscle cramps, liver enzymes raise, liver damage, etc. So we were all the time looking for a molecule which can help statins to further reduce the cholesterol and get the desired goal of LDL below 50. Now PCSK9 was available, but mainly it was an injectable one, and the cost factor was there, and therefore still in India it has not become very popular. Very few patients are taking this, and we are also reluctant to prescribe this molecule. Now bempedoic acid is the one which is now going to be available for our patient, which has got a lot of studies. The 4 clear studies have shown that it significantly reduces the LDL cholesterol without much side effects, and has now become an add-on molecule like ezetimibe. The TB study has shown that if you add ezetimibe to the statins, it further reduces the LDL cholesterol, and you can achieve the goal without increasing the dose of statins. And bempedoic acid also is a long-acting molecule because the protein binding can be given once a day, no restriction to the food, no restriction in mild to moderate kidney failure or mild to moderate liver diseases. So that way the safety is ascertained and there are no side effects, and it's an add-on effect in patients who cannot tolerate statins, especially while you are trying to target the LDL goal. So this molecule has a very good future in the future, and it is also very friendly with ezetimibe. Means it may so happen that if you want to target your LDL to 50, you may give the patient statin, ezetimibe and bempedoic acid as a triple combination, which is probably the next thing in the future, and that will help all the cardiologists to manage dyslipidemia of all patients that they treat. An observation during the Jupiter trial also that rosuvastatin increases new onset diabetes, but overall the patient tolerates well, and because of the potency we ignored that particular observation. Now bempedoic acid has proved to be reducing the onset of new onset diabetics. So on the contrary, when you give it with rosuvastatin to achieve the goal of LDL, it's a beneficial effect and a nullifying effect. I would say complementary. Rosuvastatin is going to increase nuanced diabetes, where bempedoic acid will reduce the thing. So that is a very good action of bempedoic acid, which helps you to continue with this combination, or separately this can be added to patients who are already on statins. So that fear of diabetes should not be there, should not be worry the clinicians.